treatment goals. First page. So in the treatment of type 1, there's two goals. There is what we need to do immediately and what we'll do long term. They make good sense. So you know it's a medical emergency when you first start dealing with the type 1, right? So what we do in the beginning is for the first month, we teach them what we call survival skills. We'll admit them to the hospital, and a lot of these skills we will teach them in-house. Okay? So they got to know how to take insulin. They got to know how to check their blood sugar. They have to know how to recognize a low blood sugar and treat it. They have to know how they eat, what to eat, how to match insulin and food up together. That's really important, probably the most important. So those we call survival skills. They take about 4 to 6 weeks to teach people. Usually you've got nurse educators or dietitians or whoever the team is in-house, and then out of the hospital, there's probably others that are going to be working with them to get these goals or these skills developed. If they're kids, then you're teaching the parents. So insulin administration, how, when, where, meal planning, what to eat, how to plan the meals, how to monitor their blood glucose, how to monitor ketones. So if someone's come out of a DKA, they are very likely to go back into a DKA if they take insufficient insulin. How to use glucagon. So we can use glucagon as an emergency recovery from a low blood sugar. And then what do you do if you get sick? So if you're sick, do you take your insulin? What do I eat? So we go through what we call sick day rules. So those are your survival skills. Then we have long-term. The long-term skills are what we usually want for any American, any patient. So we want them, if they're a kid, we want them to grow. We want them to neurologically develop. We want their lipids, we want their blood sugars as normal as possible. We want their lipids as normal as possible, decrease their risk of cardiovascular disease, all of that. And we don't want them to get hypoglycemic if we can prevent it. Those are long-term goals. Okay? Long-term diet goals with type 1s are pretty much for every American, I say American, everybody that you would see. There's really no, we don't ask them to eat aberrant diets like we used to. We want them to eat a healthy diet. We want them to exercise. We want them, if they're a kid, to grow. If they've lost a substantial amount of weight, we want to replace that in a healthy way. We want to keep their blood sugars from swinging big, like really high to really low. That makes them feel like crap, and it's no good on their body. We want to prevent cardiovascular disease and want them to have provide adequate calories for the insulin administered. That's one thing that patients kind of get. I have to eat because I take insulin. No, you take insulin because you eat. It's a different orientation, okay? And if for you as a provider, it needs to be that same way. If you can adjust food to correct a high or low, do the food first, do the insulin. Don't give more insulin because they're higher. Let's try to get them to eat differently and lower it that way instead of having to give more insulin. Different approach, different thought. Okay, elements of management on this next page. As much as we can, we will move people towards intensive insulin therapy. Intensive insulin therapy attempts to replace what normally their body would do for them. So we would replace them with a basal insulin, and we're going to give them insulin that will cover their meals. Okay. That's called intensive insulin therapy. So they'll have to monitor their blood glucose usually 2 to 4 times a day, maybe as much as 6 times a day. There is a balance of what they eat, how they exercise, their activity, and how we dose the insulin. And we will teach the patient a lot about how do those affect your blood sugar, and then how do you make adjustments, because we want them eventually to do all that outside of us when they're at home and make the best possible judgments. And we will individualize their blood glucose targets. So kids will have different from adults. Adults, depending on where they are in life, and comorbidities and other things will adjust. But mostly for adults, it's less than 7%, and for kids, it's less than 7.5%. Basal bolus dosing. Okay, this is important. So we're talking about type 1s. So we're going to determine their total daily dose, and we have units per kilo per day that we usually start. So if you look down at the bottom of the page, I'll come back up. But usually in adults, type 1 usually need about 0.5 to 1 unit per kilo per day. We'll usually start on the lower end. We'll start them at 0.5 or 0.6 units per kilo per day. It doesn't matter which you choose. So we'll take their weight, we'll multiply it by that, and that will give us the total daily dose. You weigh 70 kilos, 0.5 would be 35, 0.6 would be 42. Somewhere between there, that's the total amount of insulin we're going to give you in a day. Okay. Kids, a little bit less, 0.4 to 0.8. Teenagers are a little bit more. They're 1 to 1.5 as they go through puberty in the early teen years. Okay, go back up to basal bolus. So usually our basal dose of that total daily dose, so you weigh 70 kilos, we're going to give you 0.6, that's 42 units. Half to 70% of that dose will be basal. Either way you go. I tend to be more conservative and go with more basal until I know how they're going to do, and then I move usually more to the 50%. The bolus dosing will be the remainder, 30 to 50% of their total daily dose. We're going to take that amount of bolus and we're going to divide it up with the 3 meals and a snack. Based on percent, usually we give about 15 to 25% with breakfast, 15% with lunch, 15 to 20% with dinner. That's more for your benefit. Usually we're going to look more at what kind of carbs do you usually eat. We're going to teach them how to do carb counting pretty early. All right, next page, treatment principles. We are always going to use a combination of basal and bolus in a type 1. Always. 3 or more injections a day are going to be needed to get the best glycemic control. You heard me tell Taylor, 2 injections a day usually will get you an A1C of about 8 to 9%. It takes 3 to 4 injections a day to get to that 7%. We use the knowledge of onset of the insulins, their peak effect, and how long they last to design a regimen. You have to know when meals occur. You cannot interpret their blood sugars unless you know when they ate. Use your knowledge, again, of the onset, peak, and duration to figure out when they have lows what insulin is most active, because that's the one you'll need to adjust. Or you'll adjust a meal. Initial doses are based on weight. Then over time you adjust it based on their results. What are they eating once they get home, and what are their blood sugars coming back as? So we start with weight, and then we adjust based on their eating and their activity. With type 1s are very insulin sensitive, so they don't need more than a unit or 2 adjustment at a time. So here's where a 10% rule I do adhere to, because a lot of insulin will make them profoundly low. They don't have the buffer or the resistance that type 2s do. Type 2s you can change 5, 10, 20 units at a time, and it won't make a difference. You cannot do that with a type 1. 1 to 2 units, 10% of total are good rules to keep in mind. In insulin-sensitive persons, and we'll talk about how to calculate this, usually a unit of insulin will drop them 50 points. That's a lot. That's what you all do, probably 50 to 70 points. So if you're insulin sensitive. Again here, we'll make adjustments about every 3 or 4 days. So they will have a team of people. If they're kids, they usually will have a team of people that are working with them, will see them regularly, very often, to teach them more about survival skills, but also how do you interpret this? They'll go a lot of interpretation. Multi-dose or intensive insulin therapy, again, intensive insulin therapy has a definition. It's 3 or more injections of insulin a day to achieve glycemic goals. Not everybody should do it. People who refuse to monitor, refuse to inject insulin, who won't take a short-acting with every meal, people who have cognitive impairment. So there are reasons not to use it, but you should use it in any person that is willing and able to do it. Again, in constructing a new insulin regimen for someone type 1, 50 to 70% of the total daily dose is going to be a basal. So Lantus, Detamere, Levemir, NPH, Tresiba could also be in there. Your bolus or your preprandials are going to be the Novolog, the Humalog, Apidra. You could use regular. If the person can only afford regular, you can use regular as your bolus dose as well. Usually a unit of insulin will cover 15 grams of carbohydrate. And we will often start there with folks. 1 unit every 15 grams that's in your meal. So we total up the number we teach them how to recognize how many carbohydrates, or calculate how many carbs am I going to eat, and that's how many, divided by 15, that'll be how many units I will take before I eat. So that's where that insulin to carb ratio comes in. So if a patient tells you, my insulin to carb ratio is 1 to 10, then you know it's 1 unit for every 10 grams of carbs that I eat. Insulin to carb ratios will vary throughout the day. Usually we start them on a standard 1 to 15. But as soon as we start to see how their blood sugars react, we'll adjust. I found most people eat a lower insulin to carb ratio in the morning, and different times in the day it goes up. So maybe 1 to 10 at breakfast, but it's 1 to 12 at lunch, and it's 1 to 15 at supper. So they don't stay the same, but we usually start them off with a certain one. If you look at the next page, I have walked you through designing a regimen. I think for the most part, unless you're going to work with type 1s all the time, this is probably about as far as you would get. If you're going to work with type 2s, then you would be more enmeshed with them, and then you would know how to do adjustments, you would be more pump savvy. But this is something you could start if you're out in the rural area. You get somebody started on it and ship them into an endo, into a program that can give them the education and support they need. So Constructor Regimen for a type 1 who weighs 70 kilos. Okay, so 70 kilos, we're going to assume they're more of an adult, because we're going to go with the 0.5 to 1 unit per kilo. So that means we need somewhere between 35 to 70 units a day for this person. But we're going to start with initial. So we'll start with that 0.5. I picked 36 because it's easier to figure out different dosing. So the basal dose is going to be 50 to 70% of that 36. 36, the total daily dose that we're starting with. So we need somewhere between 18 to 25 units a day. Personally, I would just start with 20. You can start with 18. For the bolus dosing, it will be 36 minus, or the 0.3 to 0.5, so we need 10 to 18 units. But I'm going to subtract out those 20 that I've decided to give, and I'm left with 16 units that I can use for bolus dosing. We would teach them Some, we would either teach them some basic carb counting before they left the hospital, or we'll give them a standard carbohydrate amount to eat per meal. So we might say, you can eat 60 grams of carbohydrate for breakfast. Here's a list. One piece of bread has how many grams of carbohydrate? 15. Okay. Milk, 12 grams. So we give them a list. You can put together any combination you want, but you can't exceed 60, and you're going to take X amount of insulin for that. So we could do that if we were going to try to just buy time until we could get them into a class to help them understand. So this person, let's say they're going to eat 1,800 calories. 50% of their calories we want to come from carbs, so that's 900 calories. We divide that by 4, that gives us the number of grams of carbohydrate, that's 225. So we want them to have 225 grams of carbohydrate throughout the day. We're going to divide it up to meals and snack. Okay. So we come up with breakfast, we want you to have 60 grams of carbohydrate, lunch 75, supper 75, and a snack 15 to 30. This is a pretty typical meal setup. We're then instructing them to give 1 unit per 15, so they're going to end up taking 4 units for breakfast, 5 units at lunch, 5 units at supper, and they'll take a unit or 2 with a snack. And that's how we start. See why you need a dietitian? But you can do it. You can do it to get people started by just standardizing. Okay, this is the amount I want you to take, here's the amount of calories I think you need. You can set that just like this. You just have to work through the steps. Questions over that? I believe you should be able to understand that basic and do that. Okay. Let me go through the next 2 and then we'll stop. So how do we figure out those insulin to carb ratios? Well, often we'll start with 1 to 15 and then we'll adjust. So there's a rule of 500. So what we can do is we can take we can divide 500 by their total daily dose. Let's say we've been doing it for a few days and we've come to find they need about this much insulin in a day. That becomes our total daily dose. So we're going to divide 500 by their total daily dose, and that will tell us how many units of insulin will cover how many grams of carbohydrate. Is it exact? No. It would assume that your insulin sensitivity is the same throughout the day. It just gives you a way to make adjustments based on some guideline. Okay, so that's how we do it. Mostly I want you to know what the rule of 500 is, but I would not expect you to apply it. But I would expect that you know what we use it for and how it's determined. Okay? But I'm not going to ask you to necessarily do it. I do think you should know that we start with usually a unit for every 15. 1 to 15, common place to start. The other is an insulin sensitivity factor. This one's important because it helps us determine correction factors, and I'll show you in a minute why we do that. So an insulin sensitivity factor tells us how much a unit of insulin will cause your blood sugar to drop. People use what they call a rule of 1500 and a rule of 1800. I'm teaching you the rule of 1800 because mostly you're going to see insulin analogs. They use the rule of 1500 for regular. So what we do is take 1,800 and we divide it by the total daily dose of rapid-acting insulin. So we're not worried about the basal, we're just going to count up in a day how much bolus insulin are you taking. Take 1,800 and divide it by that. That's going to give us a number somewhere in the 1 to 40, 1 to 45, 1 to 50. So what that tells you is a unit of insulin for that person drops them 40 milligrams per deciliter. Okay? That's called insulin sensitivity. So what I want you to know is rule of 1800 helps you determine sensitivity, insulin sensitivity, and that can be used to form a correction factor. So I want you to know what it is, how you determine it, and why we use it, but I'm not going to ask you to calculate it. But here's how we use it. And with this, when I finish this, we'll be done. When we give people a insulin to carb ratio, and they take a bolus insulin, when we do that, we assume that whatever your blood sugar was before you ate, if we covered all the carbs that you ate, your blood sugar 2 hours after should be about the same as it was before you ate. Okay? So let's say your blood sugar was 100 before you ate. We had you give 4 units of bolus insulin, and you're a 1 to 15, you ate 60 grams, and guess what? 2 hours later, your blood sugar is about 100 to 130. Okay? We allow about a 30-point variance. If we get that close, we know that we are covering those carbs adequately with the bolus insulin that we're giving. That's good, because that's what you do normally, okay? So if, let's say, before they eat, their blood sugar is 150. They're doing the same thing, taking 4 units of insulin to cover 60 carbs. What do you think their blood sugar after they eat is going to be? It's going to be 150. Is that what we want? No. Okay. So what we can do is we can take that insulin sensitivity and we can correct a high in addition to what we have covered in a meal. Okay. So we want to cover the meal with that bolus, but we're going to add a correction factor to correct the high down to this point. And then they should, if it's all been figured right, their blood sugar 2 hours after they ate would be 100. Around 100. Okay. So here what we would tell them to do is for every 50 that your blood sugar is above 100, we want you to take 1 additional unit in addition to your insulin to carb ratio. Okay. So if a patient comes in and you're talking to them and they're telling you, you're saying, what's your insulin to carb ratio? It's 1 to 15. And then they tell you, and my correction factor is 1 for 50, you will know what they're talking about. That's what I'm asking you to know and why we do it. This bolus insulin will not correct a high. It will only cover carbohydrates in a meal. So you have to correct it. If it's too high, it'll just stay there. You'll just cover the carbs that they're eating. If they underate the carbs, now they could do that. They could subtract out and say, okay, I'll just eat 45 grams of carbohydrate, but I'll take 4. Same thing. That is an important concept. Does that make sense? Mm-hmm. Okay. So that's how they figure it. It's just a place to start. We will often manipulate it or change it based on the way the patient responds. Okay. So that's what I want you to know. What the rule of 18 is, why we use it, the correction factor, what it's good for. Okay. I will see you at 1 o'clock.